the surrounding normal, large moving mucosa. Polyps are usually asymptomatic, but may be ulcerate and bleed. Post teresmus if it is a rectum, and is a very large produce intestinal obstruction. The classification of the colorectal polyps is a non-neoplastic, is a hyperplastic, hematomatous, lymphoid, and inflammatory. There was no anti-malignancy potency, just some 2%. In neoplastic adenomas, tubulous adenoma, tubulous villus adenoma, and villus adenoma. Tubulous is the less chance of the malignancy, and villus is the most chances of the malignancy, 100%. In non-neoplastic polyp, hematomatous polyp is juvenile polyp, usually not pre-malignant. Characteristic polyp are childhood, but may be any age. Bleeding is the most common symptom, and intussusception and obstruction may be occur. Associated with the mutation of the PTEN tumor suppressor gene. Family juvenile polyposis. Patient developed hundreds of polyps in the colon and rectum. Annual screening should begin between the age of 10 to 12 years. Treatment mainly surgical and dependent in the part upon the degree of the rectal involvement. If the rectum is relatively studied, less number of polyps, less than 20 polyps per rectum. This is the total abdominal polypectomy in the ileorectal intestinal system. If the rectum is carpeted with the polyp, total polypectomy is the more appropriate operation. This patient are candidate in Indian pouch inner reconstruction about the permanent stone.
In this case, what are the condition of rectum in this case? But
in this multiple polyp in the
rectum also.
Is done in our case. And neoplastic polyp, this is the mainly neoplastic the adenomas. So in the family adenomatous polyposis, Gardner syndrome, Charcot syndrome, attenuated family adenomatous polyposis, hereditary flat adenoma syndrome, Muir-Torre syndrome, juvenile polyposis syndrome, Venana-Jonana syndrome, Cowden syndrome, Peutz-Jeghers syndrome, Crohn-Kite-Canada syndrome, intestinal ganglioneuromatosis syndrome, and lymphoid polyposis syndrome, hereditary and wheat polyposis syndrome. This is the malignancy of all is the adenoma. The chances of malignancy after 2 to 5 years is the adenoma to change the carcinoma.
Any percentage of incidence of all this?
It is less than 1%.
All this you mentioned because which is most common?
Family adenoma is most common. The chances of colorectal is 1% case. So other is the very rare. Adenomas fact and figure. 70% of the all colorectal cancer increase with the age. 30% of the population are 50 years and 50% are 70 years. 70% location in the left colon. 70% are solid, 30% synchronous. 70% are small, less than 1 centimeter in size. 70% have the severe dysplasia and 3 to 5% the invasive cancer. The adenoma. Chances of the adenoma to carcinoma is a duration time minimum 3 to 5 years to change the adenoma to colorectal malignancy carcinoma. This is the hypertrophic proliferation adenoma shows the picture up to the cancer up to the 3 to 5 years to change the colorectal malignancy. Factor determine risk of the malignant transformation within the adenoma. The high risk and low risk. High risk if the chances of malignancy more in the large size more than 1.5 cm, sessile flat, severe dysplasia, villus architecture, polyposis syndrome, multiple polyps, is the high chance of the risk of the malignancy. In family polyposis coli, not in our cases. Low risk is the small size, less than 1 cm, pedunculated, mild dysplasia, tubular architecture, a single polyp. Is the low chance of the malignancy. Family adenomatous polyposis is the most common colorectal malignancy. And other neoplastic polyps are there. So I discussed the family polyposis. And 1% of the colorectal cancer present about the 1:8,800 were autosomal dominant in nearly 100% penetration. There is more than 100 adenomas. Patient developed adenomas by means age in the 16 years and the colorectal mean is 39 years. Adenomas fall early, but it will take 20 to 30 years to develop colorectal from adenoma. Disease of abnormal tumor initiation. Molecular genetic of family adenomatous polyposis is caused by the mutation of the adenomatous polyposis coli gene, where tumor suppressor gene in the chromosomes 5 to encoded of the protein, which is a function of the cell adhesion and signal transduction. The mutation will result in transcripted protein and affect the cell growth. The APC gene can adenomas to carcinoma sequence. The non-epithelial mutation of the APC gene, that is plastic acid deformation, and the KRAS mutation intermediate adenoma, and the P53 gene is so chance of the carcinoma. Screening of the family identity polyposis. Gene screening the family member of APC mutation. Annual flexible sigmoidoscopy between the age of 10 to 12 until age of 40. They are the every 3 to 5 years. Ophthalmological examination, congenital hypertrophy of the retinal pigmented epithelium, and upper gastrointestinal duodenoscopy every 1 to 3 years to almost recommended the exhibit for the upper GI adenoma. Prophylactic colectomy for the familiar adenoma polyp. The aim of the surgery, treatment of the PEP, is to the intervene to adenomas to carcinoma sequence by removing the adenoma before the transformation mechanism. Timing of the surgery. If the asymptomatic patient with the modest number of small adenomas, they are able to wait for the few years for surgery as long as the colonoscopy surveillance is performed early. Symptomatic patient with a large number of the adenoma in the early surgery. The suspicious colorectal cancer as soon as possible, very early and surgery to be. Standard surgical treatment is the retrospective procolectomy with aerial pouch anal anesthesia. The first surgery is the most. And then other surgery, the total colectomy and the iliorectal anastomosis is the rectal free from the any less number of the polyps, they are free from the polyps. The proctocolectomy and the ileostomy, permanent stoma and ileostomy. In the medical treatment, not so successful, but some general somatic NSAIDs and salicoxib to show the control and reduce the number of colorectal adenomas. And no definite treatment, temporalized treatment when surgery need to be delayed, and make controlled pouch and rectal polyposis after initial profiling surgery.
How this medical treatment helps?
So that some NSAIDs to prevent the cyclooxygenase inhibitors to prevent formation of the normal epithelium to carcinoma changes. That's mainly depend on enzyme cyclooxygenase 2 inhibitors. The NSAIDs inhibit this enzyme to less chance of the polyp.
So it is 1% incidence only, that diagnosis to familial.
These are best.
Very rare case. Anybody you have found in that family, any other person you have screened?
I screened not done, but history is nothing significant. No any colorectal meningitis first and second. But
screening done?
This is not done.
So you are planning for screening?
I am planning for the second, but present party not willing for.
Dr. Malhotra, kindly you can throw some light in detail.